The Virtual Curbside is a production of the Utah chapter of the American Academy of Pediatrics, the Utah AAP, working together to improve children's lives through education, advocacy, and networking. Hi, this is Paul Wirkus from the Utah AAP. Welcome to this week's edition of the Virtual Curbside, where we bring pediatric providers together with subspecialists to get smarter about all things pediatric and better acquainted as a community of caregivers. The Virtual Curbside is brought to you in part by a generous grant from Primary Children's Hospital. Primary Children's Hospital, the child first and always. Welcome back to the Virtual Curbside. This is your host, Paul Wirkus. We're talking about psychiatric issues with Dr. Jeremy Hendrick this month. It's been very eye-opening so far. Jeremy, welcome back.
Hey, thank you for having me. It's been a great opportunity. Love talking with you.
Before we proceed, any conflicts?
No conflicts to report to you today, sir.
Any beefs?
Well, I don't know that we have got enough time for that, but
no public beefs anyway.
No public beefs. We'll put it that way.
Well, that sounds good. So we've been talking about the advanced treatment of mood disorders, particularly depression. We want to talk about some severely affected patients this week and some things that I think we have almost no idea about, but I think are important for us to know. Occasionally you'll have a patient who will end up with some of these modalities, and I think it's important for us to understand that. You ready to dive into some of the stuff that is way outside our comfort zone?
You bet. And I'll just say that this is actually an area I personally practice in our treatment-resistant mood disorders clinic. And I just appreciate, the opportunity to get the word out there about these treatments. These treatments are complex, and chances are you're going to have a patient potentially interacting with these treatments at some point. And so, just the opportunity to share some information, I really appreciate it.
Terrific. We're talking first about some technologic interventions. Let's talk about ECT. I mean, it's something that's been around for a long time. It has kind of a position in the collective imagination, I think, and probably a lot more utility than we may have been aware of in the past.
Yeah, absolutely. Yeah,
I mean, what it is, how it works.
You bet.
Yeah.
You bet. Yeah, ECT, electroconvulsive therapy. The listeners are probably conjuring all sorts of images of One Flew Over a Cuckoo's Nest, right, or somebody in a car basement with their, electrodes hooked up to a car battery. This and a couple of the other treatments we're going to talk to kind of constitute a group of therapies that we call neuromodulation or neurostimulation. And that's based on a very simple principle that we've actually known for hundreds of years. You can go back into the 1700s and actually find writings from physicians commenting on individuals with what they called quote unquote lunacy, back in that era, who suffered epileptic seizures for, some unrelated reason. But it was noted by these people that these individuals with a mental health burden had a transient improvement in their mental health symptoms after having experienced a seizure. And so that's what really led to, for the next, few hundred years, various people trying to purposefully induce seizures in patients, trying to improve, these what were poorly understood mental health conditions back then. It wasn't until around the 1930s when this treatment really kind of came into popular use in the form of electroconvulsive therapy. Prior to this, they had used things like insulin shock therapy, large doses of insulin to crash your blood sugar and cause a convulsive seizure, or CAM4 to induce seizures. It was around the 1930s when really this treatment was discovered to be safest, when you just used an electrical current external to the brain passed inward to provoke a seizure. And it's important to understand the context. This was the period of institutionalization. There were no medications. There were no treatment. If you had a severe mental health condition, you were basically resigned to a life instead of an institution. And so when this treatment came about, which at its core is the use of an electrical stimulus to trigger a seizure in a patient for the purpose of treating their mental health condition, it actually was quite effective, A, but B, it was poorly understood and therefore probably overly used and maybe even abused in certain situations. And C, it was performed on patients who were awake and alert. So a patient with ECT would come in, they'd have two metal plates placed on their forehead and have a brief electrical shock or stimulus passed into their brain, and they would have a full generalized convulsive seizure. As I mentioned, it was an effective treatment, but if you were, a member of the public, from the outside, you'd see a patient convulsing, having nurses have to hold them down so they didn't hurt themselves. It was really seen as barbaric. And so when medications did start coming out in the 1940s, 1950s, we see ECT's use almost completely go away. Well, fast forward quite a few years and quite a few antidepressants and other medications later, we just know that there's a certain population of patients, upwards of 40% of patients, who will not respond to medications and therapy. Despite the number of different medications you try, there's a certain percentage of the population that fall into this category of what we call treatment-resistant depression. And for those folks, we needed other options. And so as a specialty, we began to say, do you remember that thing we used to do? What if we kind of dusted it off and reinvented it? And that is what has brought about what we now practice, which is modified or modern ECT. At its core, that is still the process of passing a brief electrical stimulus into the brain to trigger a seizure. The difference is we do this procedure under full general anesthesia now. So a patient who is receiving ECT will have an IV placed, they'll be placed under general anesthesia. And after they're under general anesthesia, a muscle paralytic, succinylcholine, will be given that's going to block all of the muscle movement during the procedure. We then use a very sophisticated device that delivers pulses of electrical current that mimic the physiologic action potentials that are traveling down the neurons of the brain. We just deliver that at a slightly higher amplitude and frequency that propagates to trigger a seizure. Because the body is under the effect of the succinylcholine, you don't see much during the treatment. The patient's body remains still for the duration of that seizure. We do inflate a blood pressure cuff as a tourniquet, usually on the wrist or the foot, to block the paralytic from going into some area so that we can actually see some of the tonic-clonic movement to let us know that the seizure is occurring. But that'll last 30 to 60 seconds, and then the brain stops it on its own, after which the patient will wake up from the anesthesia medication in our recovery room and then go home. And that's a single treatment. A single treatment is not very effective, though. This usually requires a series of treatments, around 8 to 12, usually delivered every other day on a Monday, Wednesday, Friday cadence. And if you take that 40% of patients that do not respond to any intervention and you administer ECT, 70 to 90% of those patients will get better and will respond. And so in a patient population that is, despondent because they are not having anything that's working, they're severely suicidal, this is, one of the few treatments that's fairly dramatically life-saving in psychiatry. In addition to being the most effective treatment we have for depression, it is also the most invasive. And this is really where the important part of the conversation as it results to kids comes in, because passing that electrical current into the brain absolutely disrupts short-term memory encoding and all sorts of processes that can lead to some cognitive deficits that develop while we're doing this treatment. Those things will generally resolve after you get on the other side of treatment if you're not requiring additional ECT. But, these are developing brains. And so we want to take this very, very cautiously. And at some point, the danger of leaving a developing brain severely depressed versus a treatment like this, that the equation can really balance out to where this treatment can be indicated. The American Academy of Child and Adolescent Psychiatry has practice parameters around the use of this treatment in kids. I will say the bar for utilizing this treatment is much higher for younger patients. But yes, we do treat adolescents with ECT that have had years of failed medications and are really at a point where our lack of ability to intervene could lead to a really, serious outcome like suicide. So ECT is absolutely something to be considered, but it is something that we generally save until we've tried just about everything else that might be less invasive, which is some of the other treatments that we'll talk about as the rest of this. But it's important to understand ECT for what it is, because it's a treatment that is highly effective, but I also won't excuse the pretty significant side effect profile that it has.
What percentage of people tend to respond to ECT?
When you take that category of patients with treatment-resistant depression, we'll see about 70 to 90% of those patients get better with ECT. So it's like I said, when you compare to any of these other treatments we're talking about, if you look at the efficacy of any given antidepressant, you're looking around 30%, which separates from a placebo response of about 15%. So 70 to 90% response rate compared to some of these other treatments is pretty impressive.
And is there a significant relapse rate?
Yeah, unfortunately, none of the things that we're talking about today or that we have talked about are curative. And so that is one of the issues that we see with ECT is even if you have a great response to ECT, about 60% of patients with no further ECT may experience some relapse in the weeks following. And so for those patients, we actually can offer some additional ECT treatments in a maintenance fashion. Instead of doing this every other day, we might do this every other week or every 3 weeks or every 4 weeks. And when patients are able to be sustained with that type of schedule, it's much less impactful and much less invasive. We actually have high school students that will receive this treatment, be back to school, the next day. So it can be well tolerated in a maintenance fashion. But when you have ongoing ECT, you have ongoing cognitive insult. And so one of the trade-offs there is that there are side effects that can be more chronic in patients that require the maintenance ECT.
And by definition, is a responder then off all medications?
Generally, no. One of the things that we know is the response to ECT is more likely to be sustained if a patient is on the combination of a primary antidepressant, generally augmented with a mood stabilizing medication.
Okay. Let's talk about some other things that have letters. TMS.
Very good. So TMS, transcranial magnetic stimulation, was our effort and our hope to come up with a neurostimulation treatment that would be as effective as ECT with none of the side effects. And what TMS relies on is an electromagnetic coil that induces an electromagnetic field. And if you go back to your high school physics, everywhere along an electromagnetic field, a small alternating electrical current is generated. So if you think about your cell phone charger, the contactless cell phone charger that you set on your bedside at night, you don't have to plug it in because it sits on top of an electromagnetic coil that passes a small electromagnetic field through the charging port of your phone. And that small electrical current, alternating current that's generated is what is used to charge your phone. We just take a very high powered version of that, turn it upside down and place it over the dorsolateral prefrontal cortex. Okay, so that's this area of the brain that's right behind your eyes and has really been implicated in depression. We see it being overly active in certain mental health conditions, more underactivated in other conditions. And so the idea is that we can place that electromagnetic coil right over that area. That electromagnetic field can pass through skin and bone and brain tissue. And everywhere along that, we're actually inducing electrical current. So we can indirectly stimulate this dorsolateral prefrontal cortex with electrical current. So we're basically doing the same thing as ECT. We're just doing it very focally. ECT stimulates everything because it's a seizure all throughout the brain. TMS is going to stimulate very focally at this dorsolateral prefrontal cortex. The good news is it's pretty well tolerated. There's not a huge side effect profile. When you come in for a TMS treatment, you come in, you sit in this chair that looks kind of like a dentist office chair, has a little cradle to help keep your head still. And that magnet sits right there on your head. And it pulses on and off for about 5 to 10 minutes, depending on the protocol you're doing. It can be uncomfortable, if not maybe a little painful at first, because that has to vibrate against your scalp at a high frequency and it can feel like somebody's tapping your head with a pencil eraser. So, some people can really develop a bit of a headache with it, but that's pretty well managed. But people can drive to and from this treatment. And, aside from the theoretic risk of potentially provoking a seizure, which is a risk, it's pretty well tolerated. It does require fairly frequent treatment. So a series of TMS treatments is a treatment every day, 5 days a week for a total of 30 treatments. So you're looking at about 6 weeks of treatment here. I would say the downside of TMS is it just didn't work as well as we wanted it to. So the efficacy of TMS compared to ECT is quite a bit lower. Depending on the study, you can see response rates of 40 to 50%, depending on the study you're looking at. As it relates to kids, there's just recently an FDA indication that has been granted for one specific TMS device. Up until now, getting insurance to cover TMS in patients under 18 was next to impossible. I think that's going to start opening up. And again, TMS, I think, could be a potentially helpful treatment for your treatment-resistant depression patients that have really been through a full line of meds and are not seeing the response they want.
And choosing that as opposed to ECT is primarily based on the side effect profile and not having to go to the OR.
And again, part of this just has to do with where the patient's at in their journey. If this is a kid who can't get off an inpatient unit because they're so suicidal, that might affect your decision to move to one of these treatments or not. But TMS is absolutely a less invasive approach to neurostimulation than ECT.
Another set of letters, CES. What can you tell me about CES?
Yeah, CES, TCDS. This is a whole kind of evolving group of technologies that's basically passing an electrical stimulation more superficially. So these are, if you think of TENS units that people use for their back, it's a very similar concept. You have 2 electrodes that are placed over the frontal lobe. Usually, they're usually putting them on the forehead, but there's lots of different protocols that pass that pass a small amount of electrical stimulus. The thought being that you're doing some stimulation here that might help with depression. Unfortunately, the data is just not very good for its use, and there really isn't any good data in kids. But for adults, you can see some anecdotal reports, and I believe that there is one device, I believe it's the Miller-Fisher device, that may have an FDA approval for certain conditions. For me, this is kind of one of those, this falls into that category of, does it cause harm? And the risk of seizure, things like that, is so low that I don't think it causes harm. So, if this is something a patient wishes to trial, that's fine. As far as our ability to really give a good evidence-based recommendation to do it, though, we have to step back from that.
Okay. What about deep brain stimulation?
This is, again, at that same principle of stimulating tissues of the brain with electrical current. In this case, you're just doing it directly. So this requires a surgical approach where, an actual electrode is placed in the area that we're trying to stimulate. There's an implantable device that delivers these stimuli. The area that this is probably most used right now and is probably the highest area of interest is in obsessive compulsive disorder. So there's a lot of research and trials going on there. As far as treatment-resistant depression, not something we use as much, and not something that I have seen used in kids as well. But again, I think it's good to understand this just in the concept that stimulating tissues of the brain with electrical current tends to get you some good results. It's just we're still learning a lot on where to stimulate, how to stimulate. And I think you're going to see a lot of new technologies coming out over the next 10 to 15 years to that effect.
Given the invasiveness, is this something that's also done repeatedly, or is this a single stimulation usually?
The protocols all differ, but this is an implanted device that kind of stimulates like a pacemaker or something like that. Yep.
Gotcha. Okay, let's go to the world of ripped from the headlines. Let's talk about ketamine.
Yeah, I help guide our ketamine clinic at the Huntsman Mental Health Institute. This is a treatment that has a really interesting history. Ketamine is a dissociative anesthetic. It is an NMDA receptor antagonist. It acts at the NMDA receptor. And the reason that's important is if you look at every antidepressant that has been released by pharmaceutical companies over the last 70 years, they've all relied on the same suspects: serotonin, norepinephrine, dopamine. And then kind of out of left field comes this drug that has a completely different site of action and was used for years before its antidepressant effect was recognized. Obviously, in the anesthesia world, this is something that had been around for 30 years before it was ever, thought about in psychiatry. And the initial interest in psychiatry was the fact that a dissociative anesthetic, and when you think of dissociative anesthetics, think of nitrous oxide or laughing gas at the dentist, right? This is a medication that's used for its dissociative properties to try and relieve distress around uncomfortable situations. So at the dentist office, you're taking the nitrous oxide to kind of help you step away from the fact that you're feeling discomfort, and it can help you tolerate procedural things as well. In emergency departments, ketamine is often used at this sub-anesthetic dose, a dose that is not necessarily going to put you off to sleep, but it's enough to put you in this dissociative state. So if you're having a laceration repaired on your face, you're better able to tolerate it. So, lots of patients and even kids have received this medication in those environments. Along with dissociation comes a set of symptoms that we call psychotomimetic or mimicking psychosis. So dissociation, some people feel like they can have some mild hallucinatory phenomenon. They can feel like they have kind of interesting different thoughts than they would have normally. And so psychiatry was interested in early on from a research standpoint, saying, well, it's very hard for us to research individuals who are psychotic. What if we induce this kind of quasi-psychotic state using ketamine and then study the effect of antipsychotic drugs in these patients? Well, it turns out it was not a very good research paradigm and was not particularly successful. But a number of patients in those trials with severe depression really recognized that they felt quite a bit better. And so in those early days, the first thing we recognized is that a single infusion of ketamine, and this has been studied at different rates, different doses for quite some time, but a single dose of this at about 0.5 milligram per kilogram administered over about 40 minutes intravenously, that's where most of these studies were done, can lead to dramatic antidepressant responses. And up to 60% of patients within 12 to 48 hours will endorse remission of their depression. Their depression, the response is significant. You compare that to 4 to 6 weeks for any given SSRI or other antidepressant. So it worked very quickly and it worked very dramatically. But after a single dose, after about 5 to 7 days, that effect wore off. And so that led to the next kind of series of studies, which were all 4-week trials, in which they said, well, what if we give a second dose before the first one kind of wears off, and we stack them together? Some of these trials were 3 times a week. Some of them were 2 times a week. No real difference there. But what they could do is they could keep people better by giving them an infusion, say, twice per week for the entirety of this 4-week study. But then something really interesting happened when they held the drug at the end of the study. Instead of having relapse at 5 to 7 days out, these patients did not show relapse until 27 to 29 days out. And so we discovered that the more the patient's brain was exposed to the ketamine, the longer lasting or the more durable the response became. And that was kind of the state of the research in the early 2000s up till 2010. And that's when really the media picked up on this. It's like, holy smokes, this is a brand new treatment for depression and it works fast. And there was a lot of media excitement about it. And even though in the early days there was not an FDA approved form of ketamine for the treatment of depression, many clinics started opening up to provide this treatment. There was an explosion of clinics. All you have to do is look up at any billboard as you're driving down the street and you'll see an advertisement for some ketamine clinics out there. At the university, we took a fairly conservative approach, and we wanted to make sure that we did this treatment. If we were going to offer it, we wanted to offer it really along the lines of what the research offered. So we opened our doors in 2016 with our clinic and have been treating patients for the last 10 years, and to good effect. I think we've seen response rates very similar to what has been seen in the literature, and it is a well-tolerated treatment in the sense that you don't have a lot of the side effects that you see with neurostimulation treatments. The biggest side effects are really, you can see some hemodynamic changes. You see increase in heart rate and blood pressure. Some patients get a little nauseated, but we can run a patient through a series of, 8 to 10 ketamine treatments and get them feeling quite a bit better. I think from the standpoint of a primary care provider, because you likely are not going to be providing these treatments yourself, but you may have a patient that you want to refer for care. And I'll talk about kids here in just a second, because I think there's a separate issue to be discussed with kids. But just as you're considering where patients are going, I think the most important thing is as you're putting in a referral, you just want to make sure that you're referring them to a clinic that is safe and appropriate. And so the safety piece is, we want clinics that are going to be monitoring the cardiorespiratory status of their patient while they're receiving the medication. We want to make sure that they're also being treated for depression, meaning there probably should be a mental health provider that's involved in the care instead of maybe just an anesthesiologist who's pushing the ketamine. And so, I find ketamine to be a quite effective treatment when performed safely. There is an FDA approved form now called Spravato or S-ketamine that's a nasal spray. So there is some insurance relief for patients, but it's a very effective treatment. The question for this podcast would obviously be, well, what about in kids? And when we opened our clinic, we really kept the treatment limited to those older than 18 because the evidence just wasn't there yet. Since then, there has been some evidence that's come out. The studies are not super robust yet, but we had collected enough data and enough patients to feel comfortable, treating some teenagers, older teenagers with the treatment. And so we do treat teens in our clinic. We follow the very same principles that we do with ECT. We make sure that they get a very robust psychiatric evaluation, that we really know what we're treating, that those symptoms are there. I would say the biggest risk in that younger population is the risk of the unknown. It is really, for all intents and purposes, an experimental treatment and, should be considered as such.
With proliferation of ketamine providers, both, I was going to say licit and illicit, it does seem like there is a very gray area for ketamine these days. How much concern should we feel about people doing their own shopping for ketamine providers?
Yeah, I feel like there are so many factors to be considered as a patient, and cost is obviously one of them, right? But with something with ketamine, I don't know that just going to the place that's going to, give you the best deal is the best. I do consults with a lot of patients that may not come to our clinic, but my main goal in that consult is educating them about the risks and the things to watch out for clinics out there that may not be doing this safely. Which is also a good point to put a plug in for take-home ketamine. Technically, a prescriber in the state can prescribe compounded intranasal ketamine that patients can take home and administer. And so instead of having to come into the clinic to receive their dose, it's something that can be administered at home. My experience with that, I have yet to meet a patient that did not misuse it. Not out of malice or anything like that, but the fact of the matter is, when you take a dose of a medicine and it makes you feel better, boy, you're sure likely to take another dose of that when you're not feeling well. And it's very easy for patients to very quickly get in a situation where they can become dependent on the drug. So it is a controlled substance that absolutely requires a level of supervision that I just don't feel like is safe to be administered at home.
Yeah. Well, it's very helpful. Can we venture just a little bit beyond that then? There's a lot of talk about use of psychedelics to treat psychiatric disorders. Most of the attention has been around LSD, psilocybin, MDMA, and it really has sort of entered the popular imagination, I think powered in large measure by Michael Pollan, who wrote the book How to Change Your Mind, and then there was a Netflix series about that. And I think it's captured the popular imagination in a way that I think people feel like it's something that is almost safe to do on your own. Do you have a feeling about that?
Yeah, boy, it's such an interesting kind of time in history as far as psychedelics are concerned. You can rewind history back to, the days of Timothy Leary, and what you saw there was this evolution of a new class of drugs that even was recognized back then to have potential in the treatment of, psychiatric illness. Unfortunately, the fervor really outpaced the research. And what happened is you got a large number of people who were using it in unsafe ways that started to garner public attention. And, politically at that point, it kind of got lumped together with all of the other drugs in the war on drugs. And so it is very nice to now see, some critical, thought process around this to say like, well, no, these are not the same thing as opiates as far as their risk profile. That said, we still don't know a lot about these drugs. There is some really good early research, groups out of Johns Hopkins and some other centers around the country that have shown some pretty good evidence that there are some very good antidepressant effects from these substances. What we don't know is the details on the best way to administer them. One of the ways that these medications are really known to be effective is when they're combined with psychotherapy. For a patient that may struggle to really connect with, certain therapeutic themes, these drugs are known to be empathogenic. They're known to be able to help patients be more open and potentially even internalize psychotherapy better than without. Right. That said, we do not have a body of evidence to support their use similar to, say, something like ketamine. So ketamine just has so much more evidence as far as, safety profiles and efficacy. It's coming along. It's absolutely coming along for psilocybin. MDMA, was in phase 3 trials and came very close to an FDA approval that since met some roadblocks that hopefully will get sorted out. But my thought is these medications are not fully understood, both for their benefit and for their risks. And, there was just an article in Science fairly recently, looking at the fact that a single dose of psilocybin can alter brain chemistry in a way that we just had no idea about. And so I would just say, just because these are mushrooms that, grow in the forest that you can dry out, does not mean they're benign. There's a lot of states, well, not a lot of states. There are some states like Oregon that have decriminalized this. And, you do have the ability to do psychedelic assisted psychotherapy with psilocybin in states like Oregon, and lots of people going over there to do it. And lots of people reporting kind of life-changing types of experiences. Unfortunately, most of that still just kind of rises to the level of anecdote, and large controlled trials are still forming. We are one site at the Huntsman Mental Institute for the COMPASS trial, which is, the big multi-site trial looking at the dosing of psilocybin. And so I think we're going to see a lot of growth in this area. I think it's very exciting. I'm so excited about it. I think we're going to have so many options available to our patients. I would absolutely exercise caution here, though, to not let that same fervor overcome, the evidence that we have.
Well, for me, a fairly banal comparison would be with antibiotics, that we know that antibiotics can do good things, but we also know that there's a risk for doing harm, and that there are settings for which they're exactly the wrong thing to do. I think having some sort of professional supervision through this is the right approach.
Agreed. Absolutely.
Okay. Well, Jeremy, do you think we fixed mood disorders this month?
I think we solved it. I'm pretty sure there might be a couple of loose ends that we can tie up with some question and answer, but I think we got it.
Once everyone has listened, then we can just cross this off the list of things we need to know about because we fixed it.
I'll just say, mood disorders are difficult. They're some of the most disabling conditions we have. They can take a patient from healthy functioning to a spot of literally being on death's doorstep, they are treatable disorders, but boy, the number of patients that have refractory illness and require more sophisticated approaches over time are out there. And so it takes a team effort. I think we just want to make sure that our primary care colleagues out there are armed with the resources and things they need to support these tricky patients.
Because we have resources, and resources are both the agents and therapies we've talked about, and also the fact that we can collaborate with people like you to try to use all these modalities as effectively as possible. So thank you very much for that.
Absolutely. Happy to chat with anybody anytime.
All right. Well, you want to give them the number again?
Yeah, you bet. So the call-up line is our consultative line, Monday through Friday, 12 o'clock to 4:30 p.m. The number is 801-587-3636. Give us a call. We're happy to chat about any of your tough cases.
Terrific. Look forward to talking to you again sometime, Jeremy. For our listeners, please like and subscribe, because as usual, I feel very insecure and like to be liked. And tell your friends and neighbors about us. And please send your questions to questions@vcurb.com. Thanks to Elisa Stoddard for making this sound like a podcast. And thank you, Janice, for listening. The Virtual Curbside is a production of the Utah chapter of the American Academy of Pediatrics, the Utah AAP, working together to improve children's lives through education, advocacy, and networking. Hi, this is Paul Wirkus from the Utah AAP. Welcome to this week's edition of the Virtual Curbside, where we bring pediatric providers together with subspecialists to get smarter about all things pediatric and better acquainted as a community of caregivers. Welcome back to the Virtual Curbside. This is our monthly episode 4, where we get to ask our speaker all the questions that we've gotten from our episodes for the month so far. And by the way, thanks for all your questions and feedback. The Virtual Curbside is brought to you in part by a generous grant from Primary Children's Hospital. Primary Children's Hospital, the child first and always.